Hello to all participants of the World Congress of Melanoma 2021, and welcome to the breakout session sponsored by Natera. In today's session, we will review this Signatera ctDNA assay along with data, and we will have an invited guest speaker, Zeynep Eroglu, who from the Moffitt Cancer Center, who will discuss experience with the assay. So first, we'll have an overview of the Signatera assay and discuss and review the Inspire ctDNA dynamics for immunotherapy monitoring data. We will also review data from recently presented in Vigor 010 in muscle-invasive bladder cancer. We're using ctDNA status in the adjuvant setting as a marker for predictive of treatment benefit. Additionally, we will review current clinical challenges of immune checkpoint inhibitors in melanoma and solid tumors, and finally, share some real-world experience with Signatera and melanoma. But first, a brief introduction of our company. If you're not aware, Natera is a diagnostic company, pioneer and global leader in cell-free DNA testing. As a leader in cell-free DNA technology, we have performed over 2 million tests worldwide. Our unique molecular methods and technology yield superior sample prep efficiency, and our powerful bioinformatics are protected with over 200 issued or allowed patents. Natera has 3 business units. It has offerings in reproductive health with Panorama, which is a non-invasive prenatal screening test which provides risk assessment for fetal chromosomal abnormalities. In organ transplant health, we offer Prospera test to identify early kidney transplant rejection by detecting donor-derived cell-free DNA. And in oncology, the test in which we will be focusing today, Signatera test, which was purposefully built to detect minimal molecular residual disease, or MRD, in patients with solid tumors. All 3 of these tests leverage the same core technology, combining novel and unique methods of multiplex PCR, along with our proprietary statistical and bioinformatics models for detection and characterization of the signal of ctDNA that we're looking for. Now, the spectrum in the use of ctDNA testing in oncology is shown here. On the left is the potential to screen asymptomatic, healthy, and unaffected individuals with the goal of early detection of cancers that don't currently have effective screening methods. Now, on the right-hand side is the current use of ctDNA in the metastatic setting, where typically the tumor burden and concentrations of ctDNA are highest. This is what's typically referred to as liquid biopsy to detect mutations that have been linked to either therapy benefit or treatment resistance. ctDNA is particularly helpful in this setting, especially when there's little or no tumor available. But shifting to the middle of the diagram is the identification and measurement of molecular residual disease, where Signatera's strength lies and where we have focused our efforts. The presence of MRD by Signatera after best standard of care curative intent treatment can identify a population of patients that are destined to relapse. Signatera can also be used as a surveillance tool for early molecular recurrence monitoring. Serial testing can identify recurrences much earlier than current standard of care surveillance tools. And finally, the third area we focus with Signatera, which we'll be talking about today, is treatment response monitoring and early prediction of benefit. I'll show how dynamic changes of ctDNA and its correlation with treatment benefit can potentially change the landscape of how we design clinical trials and evaluate treatment efficacy. Now, in order to achieve this unique, personalized, and tumor-informed approach with Signatera, a sample of the patient's tumor tissue is required in the initial setup, along with the patient's blood sample. Now, this approach differentiates Signatera from other liquid biopsy tests that have a tumor-naive approach and don't take into account the genomic profile of the patient's tumor. Knowing the patient's tumor-specific mutations allows us to dive deeper in the circulating cell-free DNA to find the molecule of circulating tumor DNA that we're looking for and increase and enhance the sensitivity of the assay. The first part of the test process involves performing whole exome sequencing on the tumor tissue, as well as whole exome sequencing on matched normal DNA from each patient. Based on these results, we can identify the differences and create, if you will, a molecular signature of tumor mutations that are unique to each patient's cancer. We then look at all the somatic tumor-derived mutations and apply our proprietary algorithm to select the most important or most clonal single nucleotide variants and custom design and manufacture for each patient a personalized multiplex PCR assay that is going to target the top 16 clonal mutations found in the tumor. In the plasma, we use this personalized PCR assay to amplify those 16 targets and then sequence at a greater than 100,000 x depth uh, of read to detect presence or absence of the patient's tumor DNA in the blood. The mean of the detected target then becomes the reported result as mean tumor molecules per milliliter. And essentially, Signatera becomes a patient-specific tumor marker that can be used for the rest of the patient's life, starting from diagnosis, surveillance, to monitoring metastatic disease if it occurs. The step one turnaround time is about 2 to 3 weeks when whole exome sequencing is being performed, but subsequently, plasma time point results turn around in about 1 week. Now that I've described the approach of the Signatera assay and the technology, I'll discuss some of its clinical performance. I've discussed many issues that need to be overcome, before an MRD assay is reliably deployed in the clinic for MRD. The next step is to validate the test. The way we think of validating these tests, the MRD test, is to test for MRD status in patients after completion of curative intent treatment, which can include surgery, adjuvant chemotherapy, or endocrine therapy, and in some cases, radiation therapy. We then ask, what is the outcome of these patients who have detectable ctDNA in their blood after definitive therapy? And of course, what is the outcome to those who do not have detectable ctDNA? The performance has been validated in 4 of the major cancer subtypes. Shown here are 4 of our publications in colorectal cancer, breast cancer, lung cancer, as well as muscle invasive bladder cancer. And these 4 Kaplan-Meier curves, all these patients at early stage completed curative intent. And as you see, Signatera positive result resulted in an almost 100% chance of recurrence, greater than 98% positive predictive value if a patient is found to be ctDNA positive and no further treatment intervention is performed. Now, I'll then move on to a poll question. So you'll see, have the option to be able to answer. Are you familiar with ctDNA assays that are available today? Yes, I order routinely or am involved in a trial with a ctDNA assay. Yes, I'm familiar with them, but have not used them in the clinic. Or C, no, I am not very familiar with them. We will wait a little while, assuming we will show results soon. Okay, so a very nice mix. What we see is a 36% answering yes, I ordered routinely or I'm involved in a trial with ctDNA assay. Another 36% answering yes, I'm familiar but have not used them. And 27% answering no, I am not familiar with them. Now, before we discuss the data and applications of ctDNA monitoring in immunotherapy response, let's review some of the clinical challenges. So the indication for use of immunotherapy has increased significantly over the years. However, although existing biomarkers can allow us to select which patients we could try immunotherapy on, these biomarkers are far from perfect. Now, whether a biomarker is needed to select candidates for immunotherapy or whether a biomarker is not necessary, like in melanoma, the overall response rates and clinical benefit rate is not always high and certainly not perfect. Once we decide to initiate a patient on immunotherapy, a clinical tool like ctDNA monitoring could improve our assessments and aid our recommendations, in particular in cases with indeterminate imaging findings, including pseudoprogression, for example. Additionally, and not uncommonly, patients may achieve an exceptional response to immunotherapy, achieving no evidence of disease on scans and long durable responses. However, in cases, the risk of long-term immune-related toxicities may outweigh the benefit, if any, of continuing treatment. So a recent local draft coverage determination proposal to cover Signatera for immunotherapy response monitoring in all clinically validated solid tumors is currently under consideration. So first, I will review data that was generated and done in collaboration with investigators at Princess Margaret Cancer Center. This was published by Scott Bratman in Nature Cancer. And this was a clinical trial where patients with advanced solid malignancies who have failed standard therapy, for which there were no standard therapy existed at the time, and who remained with a good performance status, were treated with single agent immunotherapy. And in this case, it was pembrolizumab at 200 milligrams IV every 3 weeks. Plasma samples were collected and stored, and they were collected every 6 weeks, including at baseline. And of the 106 patients enrolled, we were able to analyze samples, serial samples from 94 of these patients. As you see here, various solid tumors were represented in this test, including 16 patients with head and neck cancer, triple negative, ovarian, and melanoma. One of the most remarkable findings was that we were able to detect ctDNA in 98% of this tumor agnostic sort of clinical study, basically highlighting that this assay is tumor agnostic. The biomarker can be detected in any solid tumor. Now, when we look at the ctDNA changes independent of imaging findings, here, a change in Signatera ctDNA at week 6 was a strong predictor of future outcomes. So first illustrated in the light green line, a ctDNA increase from baseline identified patients that had quick time to progression, as much as 70% of patients had progression on their first CT scan tumor assessment, whereas patients who had a decrease in ctDNA had a improved outcome relative to other patients with a hazard ratio of 0.38. This was also seen in overall survival, where patients who had a ctDNA decrease from baseline had a better outcome. Now, this is not to say that this is a test that should replace imaging results, but rather can complement imaging tumor assessment results when trying to make decisions of continuing or switching therapies. Now, just to highlight the specific subcohort of melanoma, shown here is a swimmer's plot for the samples or cases who were treated with immunotherapy and had metastatic melanoma. So what we see is that the top cases identified with the red circle, these were patients who had a decrease in ctDNA after just 2 doses. And what is clear is that most of these patients had a prolonged and superior outcome in terms of time on treatment, which is illustrated up until the point that you see a diamond, but also in terms of survival. Whereas the few patients, the 2 cases that had increases in ctDNA, had a short time on treatment and unfortunately a poor survival. Now, this assay, in addition to having that utility of looking at ctDNA change, achieving clearance was able to identify patients who had an exceptional outcome. So ctDNA decrease, seems to be needed to be able to correlate with response to treatment, but ctDNA clearance is necessary for identifying a exceptional outcome. So patients who achieve ctDNA clearance during treatment experienced prolonged objective responses, had 100% overall survival with a median of 25.4 months of follow-up beyond the first clearance. Whereas those patients who had a ctDNA increase above baseline achieved progression in poor overall survival with a median overall survival of 13.7 months. Now, in addition to that, the utility in the metastatic setting looking for a benefit to treatment, shown here is data in the adjuvant setting. In particular, this is in muscle invasive bladder cancer. This was a study sponsored by Genentech, a phase 3 randomized controlled trial of adjuvant atezolizumab versus observation in patients with high risk muscle invasive bladder cancer who were treated with curative intent. Although the study was reported in ASCO of last year as negative, meaning that the addition of adjuvant atezolizumab did not improve outcome, there was a pre-specified exploratory analysis that was performed using Signatera and that was reported in ESMO IO 2020 conference. 41% increase in overall survival benefit for Signatera ctDNA positive patients treated with atezolizumab was observed, while no treatment benefit was observed in the ctDNA negative population, showing both the prognostic and predictive value of ctDNA detection after surgery. This provides predictive evidence that the strength of the utility of Signatera and CRC and the stratification by Signatera ctDNA status should be included for clinical trials in the adjuvant setting moving forward. So, tracking Signatera ctDNA dynamics is relevant across tumor types and treatment settings. And again, shown here both in the adjuvant setting and in the metastatic setting, how achieving ctDNA clearance at any time point during treatment is associated with a favorable overall survival. Now, before we move on to discuss some of our cases, let's discuss briefly some of the current challenges that exist in immunotherapy treatment and monitoring. So another poll question: what are the top 2 challenges that you currently face when treating with immune checkpoint inhibitors in melanoma? A, identifying which patients will respond to immune checkpoint inhibitors. B, determining whether the patient is not responding to ICI and should switch to a new therapy. C, interpreting ambiguous radiographic findings such as pseudoprogression. And D, deciding when to discontinue immunotherapy. Waiting for some results. Okay, and the majority of the patients chose identifying which patients will respond to immune checkpoint inhibitors with 77%, followed by a tie between B and C, determining whether the patient is not responding to ICI and should be switched to a new therapy, and interpreting ambiguous radiographic findings, both at 62%. And 46% chose deciding when to discontinue immunotherapy. Now, just to review and set the stage for some of the case discussions, keeping in mind data from the checkpoint 067, one of the major things that we learned from this was obviously how beneficial to our patients immunotherapy can be, but also keeping in mind that the dual blockade of anti-PD-L1 inhibitor with the CTLA-4 inhibitor gives us our best outcome, but clearly not all patients benefit from the combination, and most of the benefit being derived from an anti-PD-L1 inhibitor shown here, nivolumab, improving outcome to 29% long-term. But also early on, we see how these patients that have progression very early on and no benefit, up to 40% of patients who are treated with nivolumab, or up 30% roughly treated with a combination, can be identified as non-responders or patients who don't benefit. So how might ctDNA be used to address the challenge of identifying who should receive the combination and who could start off with monotherapy is one of the questions. And then, not to mention, the importance of the chronic toxicities that can occur with immunotherapy. Shown here is data from a recently published article where acute immune-related adverse events can occur in up to 69% of patients, whereas chronic immune-related adverse events can occur in up to 43% of patients. And so keeping this in mind, especially as we move forward with the adjuvant use of immunotherapy, how can we better select patients who truly will benefit from immunotherapy is going to be a key question moving forward. So to summarize, the use of Signatera cDNA monitoring for tumor-informed and immunotherapy response monitoring include evaluating non-response at any time point during treatment and plan for alternative options. It can help clarify indeterminate radiological findings, and it potentially could identify exceptional responder with ctDNA clearance. So we'll now move on and invite our invited speaker, Zeynep Eroglu, to discuss her experience, as she has been an early adopter in terms of real-world patient experience using Signatera. So Zeynep?
Yes, thank you. So I'm a medical oncologist at the Department of Cutaneous Oncology at Moffitt Cancer Center in Tampa, Florida, in the United States. And as mentioned by Dr. Rodriguez, so at Moffitt, we had started utilizing, we had a lot of interest in looking at, obviously liquid biomarkers and including ctDNA. So we started using this assay maybe about 9, 10 months ago as part of an early adapter program through Natera. So it was cost-free for our patients. And essentially, we looked primarily to date at two groups of patients. First in the adjuvant melanoma setting, and also in the metastatic setting. And I'll just go over a few examples from each group. So in the adjuvant melanoma setting, so we looked at so far about 25 or so patients, essentially with stage 3 melanoma who had surgery, with a majority going on to receive adjuvant anti-PD-1 therapy and a few going on to observation, such as patients who may have had, prior relapse on adjuvant therapy. And essentially, we attempted to collect the plasma samples baseline post-surgery, and then at each time point that the patient may come back for either adjuvant anti-PD-1 therapy, so maybe about once a month or so, or if they would come back for scans if they were on observation. So on the screen here is one of our patients. So you can see starting from the bottom up, kind of the numbers going back to at baseline, and then as we're going up, the mean tumor mutations per ml of plasma. So this was a young patient of ours who, with stage 3 melanoma, extracellular nodal involvement, who had actually had a recurrence prior on adjuvant nivolumab therapy. So the collections start when she undergoes a completion lymph node dissection in the axilla, May 29th of 2020. So that was the date of the surgery. And essentially the axilla was the only site of her melanoma recurrence. So the surgeon was very comfortable. So completion lymph node dissection essentially rendered NED post-surgery as far as we were aware. However, you can see from the first post-surgery time points, or baseline, she did have detectable circulating tumor DNA in plasma, so that's the 0.11, which unfortunately started to, from that point forward, increase. So there's another collection done about a month later where there was an increase. The the PET CT scan done, however, in late July, still showed that the patient was NED. So essentially on the PET CT scan done a couple months post-surgery, there did not appear to be any clinical or radiographic evidence of relapse for this patient. So she was clinically, imaging-wise, still remained NED. Um, Subsequently, however, she did come back to clinic now in September, and you can see here the Signatera levels, the circulating tumor DNA going up further, significantly increasing. And at that time point, the PET-CT scan did in fact confirm relapse for this patient. So this was a case where I think we can say that the increase in circulating tumor DNA preceded the radiographic clinical relapse by about 2-3 months. Subsequently, for this patient, we enrolled her into a clinical trial that actually incorporated ipilimumab therapy, again, keeping in mind she had had prior relapse on adjuvant anti-PD-1. So this was a trial with ipilimumab, nivolumab, and actually high-dose interleukin-2 as part of the clinical trial. And happily for her, you can see that once she started on the trial, which was September 24th, we can see that the circulating tumor DNA levels subsequently significantly dropped and then became undetectable. And then the scans as part of that trial were not, for another 3 months. So starting on the treatment September, scans in December, and were also consistent with what we were seeing with the significant drop in ctDNA levels. Essentially, she had a significant partial response to treatment. And since then, her ctDNA levels remain undetectable. She's had subsequent imaging that shows that she continues to have a very strong imaging partial response to treatment. So I think this was a case, where we can see that the rise in ctDNA levels in the post-surgery setting did precede the ultimate clinical radiographic relapse, but subsequently the drop in ctDNA levels after starting a new treatment, was consistent with the subsequent imaging, the radiographic response that was seen with this patient. So I think we can go on to the next slide.
Yeah, great discussion. Just one question and one comment in regards to, the potential of clinical trial designs and where do we stand in 2021? Do you envision that at the time when there was no radiographic evidence of disease, but MRD detected, that there may be clinical trials, and what would be the challenges and limitations to designing trials like that where you treat on MRD before the relapse occurs? Do you envision something like that happening in the near future?
Yeah, I think there's, as discussed with other solid tumors, those, colorectal and other tumor types, those types of clinical trials, I think are already actively ongoing in terms of using, MRD detection to make treatment decisions. I think specific to melanoma, I do know there are, efforts ongoing and likely in design as well, currently in planning to actually be able to incorporate detection of a post-surgery ctDNA level into treatment decision making. I think ultimately what will be critical is kind of getting a better idea of sort of the lead, kind of the average or median lead detection time. How much in advance, are we going to be able to see an increase in ctDNA or detection of ctDNA prior to clinical radiographic relapse. And then, I do think, there may be other, issues such as the patient having enough tumor tissue to be able to do the assay and getting the results, in a timely fashion, which I think in the adjuvant setting, I think is more reasonable. But I do know that's an area of interest for a lot of groups, essentially, potentially incorporating this and maybe even other, biomarkers into adjuvant clinical trial design to see ultimately, could you avoid overtreating patients who maybe won't benefit, necessarily from adjuvant or don't need adjuvant immunotherapy versus, starting or switching other patients to different types of treatments.
Excellent, thank you.
So with this example, This was another patient, also with stage 3 melanoma, who underwent a axillary lymph node dissection. Had actually a positive sentinel lymph node biopsy that was removed in March of 2020. So that was the time of the surgery. And this patient subsequently went on to adjuvant nivolumab therapy. So we can see going to the top. So the patient has had undetectable circulating tumor DNA levels post-surgery. So the first time point was early May of 2020. So that's when the patient came to see us and essentially started on adjuvant nivolumab following his surgery in March. And basically, the patient would come in every 4 weeks for nivolumab infusions. And at each of those time points, we collected plasma, for the Signatera assay. So going forward, you can see it remained undetectable for many, many, many months until, and the patient had subsequent, about every 3 months, was getting imaging as well that, confirmed, he remained radiographically disease-free, clinically disease-free until November. So about 5-6 months after start of adjuvant nivolumab, we can see that his circulating tumor DNA all of a sudden became detectable. We continued with the adjuvant nivolumab. The level, slightly increased in December and then increased further, as we can see, in January of 2021. So the last imaging prior to those numbers, again in September, again, patient was radiographically disease-free. And then finally, in the PET scan done late January, that PET CT did finally detect a slight abnormality in an axillary lymph node. Again, the PET scan being late January, the rise in circulating tumor DNA levels starting in November. So patient subsequently underwent ultrasound-guided biopsy of that lymph node in February, which in fact confirmed recurrence of the melanoma in the lymph node basin. And then the patient subsequently underwent surgical resection, completion lymph node dissection of the axilla. So I think this illustrates a case of a patient who had no detectable ctDNA post-surgery, but as we can see on subsequent adjuvant immunotherapy, the ctDNA did become detectable, and that detection did precede the radiographic relapse by about 2-3 months in this case. So I think we can go on to the next case. So I'd mentioned, these couple cases where the ctDNA assay was able to, in advance of imaging, detect a recurrence. But we do know, not just with this assay, but other ones, it's not, unfortunately not yet 100% of the time, detecting a recurrence in advance. So this is a case where a relapse was actually not detected. And I think maybe illustrative. So this was a patient who had, again, with stage 3 melanoma, recurrence in the left thigh, and actually underwent surgery. So this was a dermal recurrence of melanoma in the left thigh. So that was resected in April, and I think with this case, as we can see, the ctDNA level was 0, and because this patient was on observation, he had it was an older patient with a lot of comorbid medical conditions, so did not opt for immunotherapy. That's why the collections are several months apart. There was a ctDNA collection done September when the patient came back for scans. The scans showed, again, no evidence of radiographic recurrence, no evidence of clinical recurrence. However, 1 month after that, the patient did have a skin recurrence, just like he'd had back in April, of melanoma. So this was a very small, just about maybe less than a centimeter cutaneous dermal recurrence of the patient's melanoma that the dermatologist biopsied, confirmed recurrence, and was subsequently excised. So I do think, there are obviously, some limitations to these assays. So I think maybe very small um, recurrences, such as, less than a centimeter skin-only recurrence of melanoma, maybe sort of beyond, at this point, at least beyond the resolution of these types of assays to be able to detect.
So this is a good example. So any comments on, what other factors, or maybe hypotheses, right, of any factors that could potentially contribute to an assay not be able to detect it? Of course, sensitivity at very low ctDNA levels being one, but any other aspects in terms of the biology of the disease, whether it's, dormant cells that don't shed, or potentially local diseases that that potentially may not shed. Any thoughts, hypotheses as to what else could contribute to
No,
not being
I
able to
think,
detect it?
no, I would agree with that. I think it's likely both. As with this assay, and of course others, there is sort of a level of sensitivity, in terms of how much blood we're able to collect from the
Hmm.
patients and
Hmm.
test, and
Hmm.
also the fact that, a skin-only recurrence, how much, does that shed into the blood
Hmm.
for detection again? And this was not something that showed up on the imaging either,
Hmm.
that the patient had. So I do think maybe a little bit more unique to melanoma, perhaps, than some of the other solid tumors, is when you do have these very, very small, tiny skin or dermal only recurrences of melanoma.
Hmm.
I do think there may be, maybe a little bit more challenging
Hmm.
for the circulating tumor DNA assays to be able to detect those in advance. So as opposed to, something like a lymph node recurrence or an organ recurrence. So
Yeah. Thank you.
we can go to next case. Thank you. So this was a patient in the now metastatic setting. So we had about 20 or so of these patients to date. These were patients who had not received prior immunotherapy and, were essentially starting first line of immunotherapy. So for this patient, he was a gentleman who started on combination immunotherapy with ipilimumab and nivolumab, October of 2020. Again, this is a metastatic patient, so in our experience, nearly all of these patients had detectable circulating tumor DNA at treatment start. Um, Unfortunately for this patient, you can see that when the ctDNA levels were rechecked about 3 weeks after starting treatment, there was a significant increase in ctDNA. And a few weeks, about 4 weeks after that, there was a further increase. And, in December, the patient did undergo imaging, and there was very clear evidence of radiographic progression. So, again, we can see that, with the ctDNA kind of, early on treatment, about 3 weeks on treatment with this patient, correlating with the subsequent radiographic progression. So this was a gentleman whose melanoma had a BRAF mutation. So we then quickly switched him to BRAF MEK inhibitor targeted therapy with dabrafenib trametinib. And you can see subsequently, as we get to the December 23rd time point, so that's I think about a couple weeks already on BRAF MEK inhibitor therapy, the ctDNA became undetectable. And subsequently, as he's remained on BRAF targeted therapy, his ctDNA remains undetectable. Imaging wise, subsequently scans in February and has them again coming up next month, but the scans also correlated with the ctDNA response. Essentially, he's had a great partial response so far after the switch to BRAF MEK inhibitor therapy. So I think it's a case of, you can see, clearly the initial increase on treatment with the ctDNA, which corresponds with the subsequent progression on combination immunotherapy. And then you can see the subsequent drop in ctDNA when the patient was switched to a different type of treatment, reflected in the subsequent imaging response.
So, Dr. Erlu, in these cases, these BRAF positive patients where you have more than one treatment options, you made a mention that you had quickly switched them to the BRAF inhibitor combination. Is there sometimes a sense of maybe urgency in some of these cases, whether you start off with immunotherapy or with a combination MEK inhibitor approach, where there's potentially a performance status decline that could be affected. So do you see the potential utility where maybe a clinical trial design where switching based on ctDNA response might help our patients?
Absolutely. I mean, I think, as this patient initially started on treatment, he was felt to be a good candidate for combination immunotherapy. So in the beginning, there wasn't this, need for, an immediate treatment response. So we felt
Mhm,
comfortable starting him on
mhm,
immunotherapy. But
mhm,
I think to your question, in a clinical trial design, could you use that first on treatment ctDNA level that's showing that clear rise? And potentially could you have made a treatment change at that point? And I do think uh, there are, I think, ongoing and again some studies in development as well that are looking to use on treatment ctDNA levels, after starting, whether it's potentially immunotherapy or targeted therapy, to potentially make a treatment change. I think without waiting for the subsequent clinical or radiographic progression. So I
mhm,
think potentially that's something certainly that could be incorporated into a clinical trial design. In this patient, because we were not using the ctDNA levels for treatment decision making. Essentially, we were just, kind of more, a little bit more for research purposes, kind of following along the results.
mhm,
For this gentleman, we waited, because clinically there
mhm,
didn't seem to be,
mhm.
evidence of progression. That's why we waited about 8 weeks from the start
Okay,
of treatment, and then re-image, and then there were new liver metastasis.
got it.
That was seen on imaging. But I think absolutely you could use those early on treatment time points potentially to incorporate into trial designs for treatment changes.
Thank you.
We can go to next. Okay. So another case of a patient similar to the last one with progression on immunotherapy. So this was a young patient who started on nivolumab single agent in October, again with metastatic disease. And we can see in her case also kind of with the on treatment time points, about 4 weeks later, 8 weeks later. So a clear rise in the ctDNA levels. No evidence for this patient of any clinical progression during those time points. So her oncologist, continued her on the nivolumab treatment until the first scans done about 3 months after start of immunotherapy in the metastatic setting. So getting to about end of December, and the CT scans showed, clear progression on nivolumab treatment, new, growth of lung mets, new liver metastasis that appeared. So this was a patient, her melanoma was BRAF wild type, so her oncologist then switched her to combination immunotherapy, ipilimumab, nivolumab, based on the imaging results in January. And again, happily for her, there was a subsequent drop in the ctDNA. Again, at that first level obtained about 3 weeks after the switch in immunotherapy, we can see the drop, and then subsequently the ctDNA becoming undetectable for her. The collections about being, every 3 weeks since she was on ipilimumab, nivolumab. And then the first CT scans she had after the switch to immunotherapy, also correlating with the treatment response with this patient. So decrease in the lung and liver metastasis.
Nice case of rescuing with a CTLA-4 inhibitor. Okay, next one.
All right. And then just for our last case that I thought kind of maybe helpful with regards to some ambiguous results that we saw in a patient. So this was a lady with bilateral nodal involvement of her neck with melanoma. She started on nivolumab treatment July, and for unclear reasons, we actually have I think maybe a too quick time point for her, maybe about 10 days after starting immunotherapy. So I think you can see kind of the slight increase in the ctDNA right after starting the nivolumab. So I will say there, with regards to utility of on treatment time points corresponding with response, checking within a week to 10 days on immunotherapy may be a little bit too quick. But in any case, subsequently, as she continued with the every 4-week nivolumab infusions, we can see the subsequent drop and the clearance of the ctDNA levels becoming undetectable for her. So in about over 3.5 months after starting on nivolumab, patient had CT scans done, again, corresponding with the ctDNA becoming undetectable. She had a great partial response to treatment. We continued her on nivolumab. Interestingly, February scans for her actually had this concern for progression. So actually, there looked like there may be a new lymph node on the imaging that appeared that we said, could she potentially be progressing now? But the ctDNA levels were still undetectable. So of course, we performed a biopsy, to see if she'd had progression of her melanoma, and the biopsy was negative. So so essentially, we have continued her on the nivolumab. So I think it was reported as potentially, may have been a reactive lymph node in her case. And she did have subsequent scans just done this week that's actually showing that the lymph node in question from February had actually shrunk back down. So I thought this was interesting in terms of kind of having this ambiguous result on the CT, concern for progression. The ctDNA is undetectable, biopsied, and it was in fact not a progression of her melanoma. So I think there may potentially be, utility with these types of assays, potentially, when there's concern for pseudoprogression as well.
Well, do you feel like this was a rare case, or do you not? Is this not uncommon, right? To see what could be pseudo progression this far out? I guess maybe 3 months after treatment.
Yeah, it's usually a little further out than we have seen. I know most of the time, at least in our experience, concerns for pseudoprogression are typically earlier on treatment, but I do think there have been groups that have published, with their experience with, circulating tumor DNA assays and pseudoprogression on immunotherapy, and that ctDNA may potentially have a role in terms of distinguishing between pseudoprogression versus true progression. So I do think that may be an interesting utility of these types of assays as well.
Well,
I was going to say, and then I think that's all for our
yeah, no, I was going to thank you very much for sharing your experience with these excellent cases, illustrating, the potential utility of how ctDNA assays could assist in the management of our patients. Now, with that, I will move on to ask another poll question. What scenarios do you think ctDNA testing would have the most clinical utility? And you may select all that apply. Determining molecular residual disease burden after neoadjuvant or adjuvant therapy, distinguishing true progression from pseudoprogression, determining early non-response to immunotherapy treatment and identify patients who might benefit from a change in treatment approach, helping with decisions to discontinue treatment for patients with a long-term or exceptional response, and finally, all of the above or none of the above. Okay, we're ready for answers. Should be coming any minute now. All right, and so the most common 62% of participants voted for all of the above. 23% voted for determining early non-response to immunotherapy treatment and identify patients who might benefit from a change in treatment approach. Um, so with that, I want to make sure that we address some of the questions in the chat, and I see one from George Anstis. The question is, how do you define MRD negativity in the trials? Is it one time point or more? And first, I would point out that in the studies that were done, the retrospective studies. Oh, I'm sorry. Yeah, there was where I think we missed. You wanted to. Oh, did you talk about this, Dr. Erlu?
Oh, sure, I can give a
I'm
mention. So,
sorry. I'm sorry about this.
oh, no problem. No, I was just gonna, yeah, I was gonna say, if anyone was interested further just with our experience using the Signatera circulating tumor DNA assay, um, for our patients in the adjuvant and the metastatic setting, we had put together a poster that just kind of goes over more of the aggregate data in terms of the lead time detection, and some of our experience in the metastatic setting with these patients, some of the hazard ratios and survival curves for and how the assay corresponds to outcomes. So if you wanted any further information, we had just put in the reference to the poster that's part of this conference. So thank you.
Thank you, Dr. Erlu. And so going back to the question of Dr. George Anstis, we see how do you define MRD negativity in the trials? Is it one time point or more? And I'll first talk a little bit about the studies that we had presented already in terms of the INSPIRE study. MRD negativity in that retrospective study was defined at achieving clearance at any time point. Most of those patients achieved clearance at the week 6 time point, and it was just that single one that identified the MRD negativity. But there were a handful, at least 4 patients who achieved clearance at week 9, week 12, and up to week 15. In the adjuvant retrospective study of the IMvigor010, CTD and MRD negativity and clearance was defined at week 6 after 2 doses. And we didn't do any further analysis, but some of those may have achieved clearance later on. In regards to maybe clinical trial design, Dr. Olu, could you talk about if you were to design a study and you were looking at defining MRD negativity to either potentially de-escalate, would you consider multiple time points? Would you consider a certain time frame that the patient must have been on immunotherapy, or a certain time frame that a patient must have achieved complete remission, when considering how to potentially design a study where you de-escalate a patient?
Oh, that's a good question. My preference, and I think just from what I've seen, not just with the Signatera assay, but just some of the data from circulating tumor DNA assays, is I think longitudinal surveillance of patients and making decisions based on those, as opposed to a single time point. I think the longitudinal surveillance is preferred. So essentially, in a clinical trial design, I think the design would be more robust if you were able to follow the patients, whether it's monthly or whatever your time points for collection are. And then, so for example, in an adjuvant design, and then if the patient goes from undetectable to detectable, and then potentially use that for treatment decision making, as opposed to just having one post-surgery MRD time point, positive, negative, and then make a decision, treatment
Mhm.
decisions based on that. I do think essentially the sensitivity of these assays goes up when you're able to follow the patients over time,
Uh-huh.
checking at, if they ever become positive, making a decision, treatment decision versus just at a single fixed time point post-surgery.
Mhm. And you sort of describe the approach that our hematology colleagues, have taken, when doing studies of de-escalating tyrosine kinase inhibitors in the setting of, let's say, chronic myelogenous leukemia, where it's, they have to have achieved multiple negative time points, before they de-escalate treatment. And of course, they're monitored closely when treatment's discontinued. Um, I wanted to review a couple of studies ongoing. The bespoke study of ctDNA guided immunotherapy is a study sponsored by Natera. This is a prospective data collection study of patients with advanced solid tumors who will receive standard of care immunotherapy and will be monitored with Signatera testing. And the primary objective is to examine the impact of Signatera on clinical decision making in regards to continuing, discontinuing, escalating, or de-escalating immunotherapy in the context, of course, of other clinical factors. And the secondary objective will be to evaluate, the utility of Signatera and to correlate dynamics of ctDNA changes with response, progression of disease, and ultimately outcome. There will also be incorporated a patient-reported outcome to gauge, patients' perspective. This study will recruit about, more than 1,500 patients. The initial cohorts, and this will be expanded, initial cohorts will include patients with metastatic melanoma, lung cancer, and colorectal cancer. And we do expect the first site initiation this or next month. If you're interested, please, reach out to us. If you're interested in participating, very simple design where, patients that are going to start immunotherapy will have plasma collections. And then the schedule of testing will depend on the regimen selected for treatment. Some may be every 3 weeks, some may be every 4 weeks. And ultimately a questionnaire that will incorporate the question of, how ctDNA findings may have influenced the care of treatment in the context, again, other clinical factors, including equivocal imaging or just scan results. Let's see, we have other questions. You alluded to false negatives and thresholds of
Oh, right. I
sensitivity.
just answered that one. Right. So
Oh,
I
you
think
did? Okay.
that's a great question. Again, keeping in mind our experience is still fairly limited, 25 patients in the adjuvant setting, about 20, 25 in the metastatic setting. So far, we have not had a case of, seeing an increase in ctDNA levels followed by a, clinical or radiographic treatment response. So that, may be possible, but so far we have not seen that. And then I think the last question I'm seeing, let's see, is how we chose for the first line treatment with the nivolumab versus ipi-nivo. It's a great question. In melanoma, that's always, a topic of some consideration with patients. So I think with the patient on nivolumab monotherapy, it was felt that at treatment start, she didn't have as much of a burden of disease as the patient who was started on combination immunotherapy. Also, with the patient who we put on combination immunotherapy, there was also um, question of whether we may be able to, well, just given the locations of the tumors, it was felt that he may benefit from a quicker treatment response. But there's a lot of, with the patient's other medical conditions, etc., a lot that went into deciding, between Nivo versus ipi-Nivo. And then I think with the other question on the Nivo monotherapy, if ctDNA had become positive, would we have considered adding ipilimumab? Yes, I mean, I think if the scale, again, we were not using, for these patients, the ctDNA levels to make treatment decisions, but certainly I think if there was any, radiographic or clinical evidence of progression, then absolutely we would have added ipilimumab.
Well, thank you for all the good questions. And, we are at time. I want to again, thank you, Dr. Zeynep Eroglu, for your sharing your insight and your experience with the ctDNA assay. And so certainly, we've come a long way in treating our patients with melanoma with therapies. And we hope that this tool we can prove that we can further improve upon, the outcomes of our patients moving forward. So again, thank you to all the participants and attendees. Please, reach out to us if you have any questions or concerns about the assay, about Signatera, or about potentially participating in our study. Thank you.
Thank you.